Good evening, everyone. Thank you so much for coming today. I think coming this evening, I can see everyone's joining. Lovely to have so many of you here and have so many people signed up for this evening's webinar. Um, Thank you very much for coming. I'm just giving everyone a little chance to join the room. Thank you. Excellent. So my name is Dr. Sam Manger, for those who don't know me. I'm a clinical GP in sort of 50% of my professional week, and then the other 50% of my professional week is across various roles. So as relevant to tonight, I run the postgraduate degrees, master's, graduate diploma, graduate certificates in lifestyle medicine, and also supervise for some PhD students. And within that, there's clearly teaching and research and various projects that we run and grants that we've got, which is great. And then I consult fairly widely as well. And this is sort of independent consulting in industry for government and other sectors, including the RACGP on their Shaping Healthy Australia project and Handbook of Non-Drug Interventions. The real interest here is with consulting, if any of you is particularly interested, is the opportunities within various parts of healthcare, private healthcare insurers, public sector, primary care sector. There's a huge demand for looking at whole of person, whole of community approaches to health prevention, but also chronic disease remission. And so this is certainly an area where there's a lot of interest. And tonight, that's what I'm going to be talking to you about. It's a bit of an introductory talk about what is lifestyle medicine, lifestyle as medicine, and then covering some of those key studies around looking at not just prevention, but how can we actually use lifestyle in management combined with other forms of management, aka pharmaceutical approaches, procedural approaches, psychotherapeutic approaches. But also how can we lead to remission? And that's a more modern word, chronic disease remission. Typically, we talk about diabetes remission the last few years, are a bit more comfortable and brave talking about that. But what I have seen both from the research, but clinical practice, and more as the years progress, is to me this concept of, okay, when a chronic disease remits, what's happening? Well, really what's happening is the physiology is starting to heal. That metabolic disease is starting to get better, fatty liver is resolving, insulin sensitization is returning, blood pressure is normalizing, and so on. So we're actually talking about healing here, though that's a little bit of a, say, maybe a bit of a soft word, a bit of a woo word, but nonetheless, I think it's actually a critically important word when we're talking about healthcare. So I'm going to be talking about the evidence, as I say, some key studies, and then some aspects of implementation, but within the limits of what I can cover tonight, which we've got an hour, so let's try and get as much as we can. Now, if you have questions, I absolutely welcome them. I will save them for the end. We have a question and answer box within Zoom, so please do throw those questions in, and I'll go through that. Look forward to having conversations with you at the end of this presentation. So first, just going to acknowledge Australian Aboriginal and Torres Strait Islander peoples as the first inhabitants of this country and pay my respects to the traditional owners and elders past and present on the land on which we stand today. I'm on the Sunshine Coast in Queensland, southeast Queensland, and that's Gubbi Gubbi land. So just acknowledging traditional elders past and present, and in the spirit of reconciliation, just acknowledging the valuable contribution that First Nation peoples make to James Cook University and the broader community. I also want to acknowledge you, the audience, because I recognize that there is an enormous amount of expertise, professional expertise and personal experience here tonight. And I recognize that very likely you are all health professionals with considerable expertise, and that's wonderful. And I thank you for your amazing work and your good work. And I hope what I provide you tonight it contributes to the good work that you already do. Now, the other thing I'm going to quickly disclaim is I always like to do this little stop reality check because I don't want people thinking that this is sort of some ideological campaign. One of my favorite quotes is by the great scientist and communicator Carl Sagan, who said, "It pays to keep an open mind, but not so open your brain falls out." And I think this is adequate for this part of medicine because it can sometimes be hijacked a little bit by ideologies or by certain tribes. And I really try and avoid that. I absolutely have seen in the research and in my clinical practice and experience and in my own life, the power of addressing the roots of health and well-being, addressing the lifestyle and social factors. When you do that, you see the physiology change. As I say, you see remission occur, sometimes healing occur. But also, I'm not pretending that it's a panacea, that it's a cure-all, that it can fix everything, that we never need to take another pill again, that surgery is just, not needed. Absolutely not. It has its place. It is incredibly effective when combined with existing treatments like psychotherapy, which I'll touch on, like surgery, which I'll touch on, like medication, and so on. So, these aspects, we have a fantastic healthcare system. We're so lucky. But really what we're talking about here is evolving it to meet the challenges of the times. But clearly, medication procedures are life-saving, life-improving. But the case I will make lightly and quickly tonight is, are we over-relying on those reactive, fairly costly and potentially side effect burdensome approaches at the expense of addressing lifestyle and social roots, which can support a lot of people? So that's just my little claim around that. Hopefully that puts it in context. The little brain doing some weights there is just to say that each one of these slides has about an hour lecture behind it, which we provide in the master's and graduate diploma and so on. So there's a lot of nuance and context and extra information around all of this, which I'm more than happy to talk to you about in the Q&A. And if you let me, I'll just keep on talking. So I have to contain myself. So let's just talk about a little bit of context. Again, just please accept a disclaimer here that I am, within the sake of time, I'm just making points. There is obviously nuance, gray. It's not black or white. But just to understand the state of healthcare at the moment, and this is a little bit GP centric, but it's true for most medical providers. It's true for psychologists. It's true for allied health and primary care nurses and the many other health professionals that service our community. But we are all, I think, from experience, if you're a health professional, I'm sure you're seeing this, we are all seeing more problems. We are seeing more complex problems, and we are seeing more number of problems. This is true in the research. The average GP manages about 3.5 problems per 50-minute consult. 3.5 problems actually sounds like not a lot to me as a GP. It's usually like 5 or 6 problems within a consult. And that is not a sustainable approach. We've got more complex disease. We're having to refer a lot more. We're doing a lot more pathology tests, a lot more radiology tests. And this is contributing to a worn out health profession. In the UK, the British Medical Association did a survey and found 41% of doctors have depression, anxiety, stress, or burnout. In the RACGP Health of the Nation report, the preceding one before this one, highlighted that 71% of GPs report symptoms of burnout. 64%, almost 2/3, are considering reducing their time because of this. And we're seeing this in practice. A lot of GPs are going down to part-time because this style of sort of throughput medicine is just, it's not satisfying to us and it's not satisfying to patients as a general rule, and there's a huge weight on it. And we talk about this sort of background burden that's sort of filtering onto the front line of healthcare. We're seeing there, I'm not sure of any particular disease that's getting better when it comes to prevalence rates and impact rates. We're seeing pretty much all of them get more prevalent, and we're seeing them happen younger. So these are bad trajectories. If we look at just diabetes as an example, because it's a topical example, right now about 21% of Australians have diabetes or prediabetes. That's very likely underdiagnosed, so it's likely more. Between the years of 2000 to 2020, we saw almost a tripling in the number of people who had diabetes. And this is a global trend, as you can see here on the right, much worse in certain countries like Polynesia, Micronesian countries. But these are deeply worrying trends when we already know that about 70% of the population are overweight. If you look, okay, what's going to happen in the next 10 years with things like metabolic disease, fatty liver, and so on, these are frightening. But this is also true for mental health. And again, I'm more than happy to dive into the nuance of this. This paper published in the Medical Journal of Australia in 2017 looked at rates of mental illness and saw that despite the fact that we are prescribing more than we ever have, we're providing psychotherapy more than we ever have, mental illness rates on average are not changing. But this much more recent report that came out last year from the Melbourne Institute actually split it up between ages. And as you can see here, the darker blue lines are the younger populations and the lighter blue lines are the older populations. And you can see here that the mental health rates in particular of our 20s, teenagers, 20s, 30-year-olds is tanking. It is going right down, which is very terrifying. When you look at this graph, things were actually starting to get a little bit better up until about 2007. And then something happened around 2007, 2008. Maybe we can reflect on what that is. It might be social media, but there are various reasons for this, but these are alarming trends. And as I say, and how are we responding to this as a healthcare system? Well, in many ways, and I'm going to touch on this again, that this is not because of a lack of effort and care and compassion and intelligence and hard work of the health. That's not the problem here. This is a systemic problem. This is a model of care problem. This is a funding problem. This is a training problem. If we look at how we are largely responding to this worsening trends, we're largely responding to this with more medications because that's how the system is designed. Before COVID, 1 in 8 Australians were taking antidepressants. Now it's about 1 in 6, 1 in 7. We're the second highest country in the OECD to prescribe antidepressants, only just behind Iceland. In most countries, Australia, UK, New Zealand, we are seeing a massive increase in the prescribing of antidepressants to manage the psychological and social distress and biological distress that is occurring in our population. In New Zealand, this paper showed that for teenagers, we have increased the amount of psychotropic prescribing by about 60 to 70%, including a 100% increase in antipsychotics to teenagers. And if we look at physical disease, about 75 to 98% of diabetes is managed with medication. And studies show that about less than 8%, some studies even worse, are responded to with lifestyle interventions to any significant degree. So we have a very pharmaceutically dominant model. Again, it's not that that's anything wrong with pharmaceutical medicine. I am very thankful that we have pharmaceutical medicine. It's a fantastic thing to have, and full stop. However, the question is, when we look at us as a system, how we're responding to these, what are often lifestyle social rooted diseases. This is a table from the Royal College of Psychiatrists in the United Kingdom, just to show again that 10 years before COVID, 100% increase, aka a doubling in the number of antidepressant prescriptions in that time. And there is now a major movement in the United Kingdom to be much more conscious of this and to talk about deprescribing, which I'm not talking about tonight, but I have done a podcast on. Oh, that reminds me, that's my other thing that I do. I have a podcast for health professionals called The GP Show. Been a bit busy in the last few months, but I am going to get back into it soon. But I did an episode on deprescribing if you're interested. And what does that all mean? Well, it means that there's more demand. There's more demand on us as GPs, on psychiatrists, on psychologists, on allied health providers. It's just going up. And what does that mean? It means a very, very costly healthcare system. And the question is really, is this sustainable? So this has been reviewed. Major at the Victoria Uni Minch Institute, Professor Rosemary Calder and co reviewed this in 2019 and said, yep, we've got a good healthcare system, but business as usual is not an option. These trends and trajectories cannot continue the way they are. We need new ways of financing, keyword, and delivering high quality contemporary care to manage this. So that's really my professional mission. My professional mission is to help our healthcare and contribute, as we all are contributing, but to contribute to the body of good people here to evolve healthcare so we can address the lifestyle social determinants far more effectively. But it's, again, as I say, it's not because we're not trying. I mean, the reality is over the last 20, 30 years, the only reason I think the healthcare system has managed to stay afloat, and now we're seeing in UK that it's not staying afloat because this has been over abused, is that health professionals have tried to compensate. And this actually has been made clear in the Productivity Commission 2017, despite these poor models and financing, that are largely accomplices of illness rather than wellness, it's only encountered by the ingenuity and ethical beliefs of providers to swim against the current. So also, thank you watching this and the people who are going to watch this on recording. Thank you to the people you work with, because we have been working hard despite this. But now is the time that we need to change the systems and lead that change. And I think in Australia, we have that opportunity. But lifestyle medicine is a global movement. But nonetheless, there's a lot we can do here. And so Lao Tzu, the founder of the believed founder of Taoism, or the author of the Tao Te Ching, said, if you do not change direction, you may end up where you're heading. And I look at these trends and many other trends, many other reports, and I'm really worried about the direction we're heading. And the question is, what can we do about that? So that's context for you. Hopefully that few minutes there just helps. And this is not, this is not controversial. The 10-year primary care plan highlighted this. It said we need to move from an illness system, which is what we have, to a well-being system, a whole of person, whole of community approach. We need to move to a reactive system to a proactive system. We need to focus not just on treatment, but on prevention, and they didn't put it in there, but management and remission. We need to work on an interdisciplinary team, a value-based system, and coordinate better. Mark Butler at the recent GP conference last month said, Australia walks the path to more multi-D GP-led primary based care. But my question is, okay, yeah, that's nice to say that, but what does that actually look like? How do you actually achieve it? There's the plan, there's a 10-year plan, but what's the plan to achieve the plan? And they're the blanks that I'm not sure are being filled. And that's where we as a profession can step up. So what is lifestyle medicine? Lifestyle medicine, as I've now made clear, is addressing the lifestyle and social determinants of illness and wellness. And by doing that, you improve the physiological aspects or the cellular and molecular mechanisms of our internal systems, which then lead to changes in disease state, right? So fairly self-explanatory. There are some things that we are more able to change: diet, sleep, mind-body interventions, so on, physical activity. There are some things that we need to be very aware of, such as childhood trauma. And there are some things that are harder to change, say the macro determinant policy factors, environmental, social determinants. However, that doesn't mean we can't change it. And again, I'm going to talk about this a little bit around implementation, but we can have a huge impact by simply assessing social needs, aka accommodation, personal safety, education, and so on, and matching our management accordingly, but doing that in a structured, systematic way. And also, there is the middle ground between individuals, which often what we see in healthcare, and the macro, and it's called the microenvironment. And they're things like communities, schools, workplaces, and obviously healthcare settings. And we have a big influence on those microenvironments. And those microenvironments have a big influence on the individuals within them through various social norms and so on and so forth. So we can have a big say. There's a big role for health professionals stepping up in a proactive way into these different settings, or changing the way our clinic is done, for example. And I'm going to talk about some of these markers, cellular molecular mechanisms. So I used to talk, it's been called for many years the 6 pillars of lifestyle medicine. I think there's more than 6. I now call them the ingredients of lifestyle medicine. And the reason I do that is because it's like a recipe. You have your common ingredients, but what you make with that is different depending on the person in front of you. It's different depending on the setting you're practicing in, and how you implement this from a model of care point of view is different. And again, I'm going to go through a few examples. There is no one size fits all, neither with each ingredient or with how you implement this in an individual or model setting. But the key ingredients are nutrition and fasting, and there are many different types of fasting: time restricted, 5-2-1-1 fasting mimicking diet, etc., etc. Movement, and there are obviously lots of types of movement. Mind-body approaches, mindfulness, relaxation therapies and response training, autogenic training, breath work, and so on. Sleep, reducing harmful screen and substance use, so pathological screen use is wrapped into that. Social connection, huge, massive one. Nature prescriptions or green prescriptions, creative arts, social prescribing, and addressing social determinants. So they're the ingredients. Then we've got the drivers, and the drivers are, okay, what are the things that's nice to have those ideals, but what are the things that actually help you put it into practice to help support behavioral change? So one is actually understanding behavior change science. It's not something that you might have got a little bit of, say, trans-theoretical model of change or motivational interviewing training in med school or wherever you came from. But health coaching, for example, and behavioral science, behavioral insights, built environment changes is an enormous field that marketing and other industries have been using for a long time to make us buy things we don't really want or need. But it's time we start using this incredible body of research to help people make the best decisions for themselves. Then we've got the model of care. So zooming out a little bit and thinking about the community settings, what kind of are we running? We doing, and again, I'm going to touch on this in a bit of detail. And then we've obviously got the technology and the research behind it. And all of this is personally and culturally adapted. And again, what I mean by that is it's not a one size fits all. What lifestyle medicine is not, these are things that have come up over the years, not for quite some time, I will say, but they used to come up a bit, so I'll mention it nonetheless. Is it alternative medicine? No, it's foundational, real, rigorously evidence-based medicine. It's not homeopathy, energy crystals, not to dismiss any of that stuff, but just simply it's not that. It's rigorously evidence-based. It's foundational, common sense medicine. Is it medicine for wealthy people? That's the one that pains me the most when I hear that. I mean, that really shouts ignorance to me when people say that. I've worked as a GP. I've bulk billed 89% of my patients, 90% of my patients, according to Cubico, for many, many years. I ain't here to make money. And I've worked as a GP special interest in the psychiatric services in the public system for 5, 6 years. I've delivered lifestyle medicine programs to all different demographics and backgrounds, to homeless people, to people with schizophrenia, to people on the NDIS, to people, yes, to wealthy people. And to me, this is about the best healthcare. This is about health equity. Everyone deserves the best healthcare. That's what this is. It's completing the picture of healthcare. And as I say, it's not one size fits all. So let's get in now into a bit of the science. So thank you for hearing all that context and definitions. Now, we've known for a long time that a lot of this chronic disease is preventable. 80% of the risk of chronic illness in some studies, like this study, and this has been repeated and repeated, of our most common chronic diseases, heart disease is preventable, 93% of diabetes is preventable, at least a third of cancers are preventable with a few simple measures, probably about 40% of dementias are preventable, and so on and so forth. But it's not, for whatever reason, humans, we are short term as a general rule. We are a little bit reactive as a general rule. So prevention is great and really important at a macro level and a micro level, but it may not be the thing that triggers change in people. What triggers change in people, I think most of us, is when people get a bit sick. So there's a perfect place for lifestyle medicine as a intensive intervention as part of management and ideally remission. So let's talk about remission. So this was a study done in the 90s, and it's been multiple style studies of this done over the last 20 years. I can count about 6 to 7. The biggest one being CardioPrev that came out about a year ago, where they looked at carotid atherosclerosis. But I'm just highlighting this one because it's just a good seminal study to talk about. This is a 5-year randomized control trial, lifestyle medicine intervention, whole foods, plant-based diet in this example, aerobic exercise, stress management, smoking cessation, and group support. Often what the lead authors here said, the secret ingredient, the group element. After 5 years, what they saw, they did this at 1 year and they did it again at 5 years. What they saw was that in the experimental group, there was an 8% reduction in the stenosis diameter, and in the control group, almost a 30% worsening. So that's about a 35% difference in stenosis. That's the difference between 70% stenosis or 80% stenosis, which is clearly stent and high risk territory, to 35% stenosis, which is clearly lower risk territory. Also, those plaques all became much more stable, much less likely to cause a cardiac event. And if that doesn't sound like a lot, 8%, there have been studies showing that a 1 to 2% reduction in atherosclerosis diameter can reduce cardiac events by up to 25%. So, changing these things and making them more stable is a major point. This angiogram on the right, so that's the left anterior descending artery. That's the sort of widowmaker, if that's the one that gets obstructed by an acute rupture of one of those atherosclerotic plaques. You can see on the image on the left that this is that moth-eaten image whereby there's lots of atherosclerosis, there's very poor blood supply, which is the dyed area, the white area that you can see. After 32 months on the lifestyle medicine program, that artery has opened up. That blood flow is beautiful now. As I say, this has been repeated in carotid atherosclerosis and various other sites to show that, yes, it is possible. And now they're breaking down more recently different elements of interventions. So the Mediterranean diet, they're now looking at how that can reverse carotid atherosclerosis and other atherosclerosis. They're looking at different variations of exercise, intermittent high intensity training. And actually, after 6 months of that, it can actually start reducing atherosclerosis as well. So we're starting to get better research now about which aspects are doing what, but they are all contributing to this healing, the body actually healing itself. Because remember, that may be in the heart, but there's likely atherosclerosis everywhere, peripheral vascular, in the cerebral vasculature, aka strokes, renal vasculature to cause high blood pressure, and so on. So if we can start reversing this process, 2 thumbs up. If we look at diabetes, given, as I said, the prevalence and trends here, this was published in the Lancet only 7 years ago. It was really one of the first major papers to say, actually, we can put diabetes into remission. When I was in med school, we learned, that diabetes is unmanageable well, it's only manageable, it's unreversible, irreversible, and it's just going to be more and more medications until eventually everyone's going to be on insulin. They used to tell us. But we now know that that's not the case. The the fundamental pathology here, which is insulin resistance, can be reversed. You can become insulin sensitive again. You can process carbohydrates again. But there is a process that has to be undergone here, which is an anti-inflammatory lifestyle directed process. So this one specifically, and like I said, I could pick many other studies since, but this is just such a seminal study published in the Lancet that I thought I would use this one. That it showed that if you've been diagnosed in the last 6 years and you've lost enough weight, you could 80% of people could be put into remission, and on average 46%. And there were multiple dietary approaches. The American Diabetes Association, then in about 2019, I think this was, yes, did a summary here and actually said there's lots of different dietary approaches where you can reduce your HbA1c and your risk of diabetes. Some had more evidence than others at this current point in time. And they said there's strong evidence to support the effectiveness of dietary interventions. Yes, I agree, supported by registered dietitians for improving HbA1c, which decreases up to 2%. That's actually really conservative. Here's a patient of mine. They came and saw me for a second opinion, very poorly controlled diabetes. They're on 2 medications. The obvious choice here is to add a third medication. They really wanted a different approach. We started a lifestyle medicine approach. Within 3 months, the HbA1c went down to 6.1. I then stopped one of their medications. I kept the metformin going because it's a good drug generally. And then they went down to 5.8. And now, this is continued. This is a little old now. It's a year and a half old. And I'm still seeing this patient, and their numbers are still the same. They've lost weight. Their blood pressure's come down. This person was, I don't think, good. There's no date of birth there. This person was only at 40. So this is the trajectory of this person's life completely changed. And if we look at this is published in the Lancet Diabetes in 2020, where another randomized controlled trial where they compared intensive lifestyle interventions with current best practice standard care. So standard diet advice, exercise advice, access to medications, access to dietitian, access to a diabetes educator, right? And this is an overarching point I'm going to make in this talk, which is that we have a great opportunity here. To really take this lifestyle medicine to the next level, to make it more intensive, to make it more personalized, to make it more effective, to build it fundamentally into our healthcare systems so we can support people in a much more impressive way. These are the results. So you can see here that in the intervention group who had the intensive lifestyle medicine intervention, 61% of them went into remission after 12 months versus 12% in the control group. A third of them went into normoglycemia, where the HbA1c went less than 5.7. We saw increased in insulin sensitivity. And in the intervention group, we saw a reduction by 1.5 medications per participant at 12 months, versus in the control group, we had an increase in about 1.5 medications. So that's almost a 3 medication difference between the two groups after only 12 months. So that's great for the patient in the sense of better diabetes control, but it's also, it's less cost because of less medications, less side effects, and the side effects to medications I think are largely underreported. And so this is a win all round. Now I'm going to move on a little bit because I'm going to try and sort of do a variety of different conditions. So it's going to come across like I'm jumping around a little bit, but what I'm doing is just showing you the breadth of opportunity there is here. So this was a massive systematic review meta-analysis looking at structured, so not just tokenistic, here's a bit of information, eat well, do more exercise, but actually structured and supported dietary and physical activity, which are only 2 domains of lifestyle medicine, but nonetheless, a key too. And led by Professor Helena Teed at Monash, the great team there. And there were a lot more stats here, but I've just picked a few for you. But what they show, if you just pick a high yield part of life, aka antenatal, when women are pregnant, very high adherence rates during this period of life for obvious reasons. And so this is a very good time to be doing lifestyle medicine. And what they saw in this was was a significant improvement in both maternal and neonatal outcomes. So 32% reduction in neonatal intensive care admissions, a 25% reduction in total adverse maternal, and a 56% reduction in total neonatal adverse outcomes. So that's incredibly huge. And the cost saving of this is $500 million per year in Australia. Just from targeting this one little part of healthcare, we can make such a difference to the mother, to the baby, to future families, and so on. Sir Michael Marmot, who's one of the godfathers, leaders in public health, and so he essentially did the first studies on the social determinants of medicine back in the 70s in London, and back then they thought, oh, there's no evidence that social determinants impact physical health. They're completely separate. So he was put these two together and actually said, no, social factors make a big difference to people's health. But he did a report called the Marmot Review about 15 odd years ago, and where they looked at what are the biggest factors that can affect health equity, and that was giving children the best start in life. All right, now if we look at men's health now this is a trend that is really worrying as a man, but just broadly as a GP, this is a worrying trend. This was the NHANES database, which is a very well-respected database. Over 4,000 men were looked at, and they saw that over the last 20 years, give or take, the mean testosterone in men has reduced by 25%. Now, some people say this is not a bad thing because it makes men a little bit less, aggressive and whatever it is. I don't agree with that. Obviously, we don't want people to be aggressive, but I think what we see is a broad range of consequences from this. Poor energy, poor motivation, worse mental health, less drive, less sexual function, poor relationships, an innumerable number of impacts from this. This correlates pretty strongly with increasing BMI and metabolic disease, because it's also clear that those who do maintain a healthy lifestyle, their testosterone can actually stay, reasonably normal up until their sort of 70s or 80s. And the factors, as in the Australian Journal of General Practice in 2019 was a nice little quote here. It said, most men present with androgen deficiency symptoms don't have an organic hypogonadism like a brain disease or testicular disease, but they have a functional gonadal axis suppression due to ill health. So we are poisoning ourselves with these lifestyle and social determinants. We are literally suppressing our hormonal axis in our brain. We are impacting our immune system. No surprise, we're seeing allergies and autoimmune diseases go crazy. I just can't see how this cannot be addressed. This has to be addressed. Now I'm going to jump to hospitals because I just want to make the point around the context again that there are specific areas where lifestyle medicine can just plug in. It doesn't have to be just a nice conversation about diet and exercise in primary care. There are so many opportunities where you can plug lifestyle medicine into the system. So if we look at lifestyle medicine perioperatively, so people are going in for elective surgery, there are various studies suggesting that between 20 up to 70% of people who go in for to admitted to hospital have some degree of malnourishment. Now that sounds like an alarming stat, but remember that people going to hospital are generally sick, usually a little bit older as well. And when they do nutritional analysis, these people, very high chance they'll be deficient in some category. Whereas if we do the opposite, if we optimize people's nutrition before they go in for surgery or when they go into hospital, funnily enough, they heal quicker. And there are actual specific formulations, omega-3s, zincs, various amino acids like glutamine, glycine, arginine, and so on, that you can give people to prepare their body for the major stress that is coming, aka surgery. When you have surgery, your demand for calories, protein, micronutrients jumps up huge. Why? Because we just went through this enormously stressful event. Someone just cut our chest open. We got a lot of healing to do. And when you heal, you need more to heal. So if we support people with more nutrition before and during, stronger musculature, stronger cardiac aerobic, VO2 max, so on, fitness levels, better mental state preparation, better navigation, then we're going to have better outcomes. And these papers on the right are just a few that I've picked from the last few years, meta-analysis, systematic reviews, high quality evidence showing that when we do these things, whether it's high-risk surgical cancer patients, joint replacements, abdominal surgery, We see less infections, which is great. We see less morbidity. We see less pain. We see less complaints to staff. We see a significant reduction, over about a 40% reduction in length of stay of hospitals. That's assuming the average length is 5 days. It's about a 2-day reduction, and it's safe, and it's quite cheap, and patients want to do it. So that seems to me kind of important. This is just, again, a lovely study that was published last year, systematic review meta-analysis of high-intensity interval training, just again to highlight how recent some of this research is and how we're really actually starting to understand how can we tailor specific, high-yield, more intensive interventions to address those roots to improve physiological outcomes and psychological outcomes. So this was high-intensity interval training, or HIIT training, it's often called. And the results of this meta-analysis suggest that preoperative HIIT may be beneficial for certain populations. By only improving the exercise capacity by 10%, we reduce the post-operative complications by 56%. So there are, as I say, opportunities here, opportunities that can be realized. That was moderate quality evidence, 770 people. Obviously, the study's there if you want to look at them. This is one on mind-body interventions, and I'm a bit of a fan of mind-body interventions. I think this is another massively untapped area of healthcare. This was a randomized control trial published in Pain, very respected journal. 2021, so a few years ago, one of the largest clinical trials of mind-body interventions ever done, pre and post, following total joint replacement. And what they saw was that doing mindfulness meditation leading up to surgery, it did things you would expect to do: reduced anxiety, reduced pain medication requirements, reduced pain intensity. So that's good, perhaps not so surprising, because those are the kind of subjective aspects, very hard to quantify pain, for example, and you would expect some mind-body intervention to have an aspect to that. What was less expected was the post-operative outcomes. And what they saw was at the 6-week mark compared to the control group. So the control group's function at 12 weeks, their daily function, was the same as the interventions group at 6 weeks. So that means that the intervention group healed, inverted commas, aka rehabilitated, or were able to return to a pre-surgical functional state twice as fast as those who didn't. Now, again, I'm going to come back to my little reality check, which I said at the beginning. I think all of this deserves to be scrutinized. Studies deserve to be repeated. The effect size maybe not be this impressive, but even if it's 2/3 this size, but these are good quality trials, even if it's only 2/3 this size, this is still a really impressive outcome for something that's safe and free, pretty much. And this goes right down to the level of genes. And I just like to throw these things in because it's just so interesting to me, because I was talking about the cellular and molecular mechanisms that these things impact. One of the many mechanisms this impacts is it goes right down to the level of your chromosomes and your genes, right? As we age and get sicker our telomeres shorten. Telomeres are the caps at the end of our chromosomes that are obviously got a response in protecting the DNA and a whole raft of little jobs. But as they get shorter, they correlate with symptoms of aging, chronic disease, senescence, and so on. Major work by Elizabeth Blackburn, who I believe won the Nobel Prize for this, though I'm cautious to say that, but that's from my memory, started doing a lot of the work on telomeres and lifestyle interventions. And then more work has been done since there. This is a meta-analysis, and it actually showed that mindfulness meditation, as can other lifestyle interventions, activate an enzyme which starts adding DNA base pairs onto the end of chromosomes. It starts lengthening chromosomes again. So we can actually reverse, aka heal, reverse these metrics of disease and aging right down to the level of the chromosomes. And so, there's now more and more papers, and this is why I'm really passionate about this. This is why I'm very passionate about teaching about this and about supervising master students and so on about this, because there are so many opportunities within the healthcare system to plug this in. This is just one paper where they actually started to structure this in a way that was low cost, low staff requirements, very effective, all the things that we want it to be. So just an example of the various models of care we can build in. Now I'm going to move to mental health. So, two sides of the same dice here: mental health, physical health, social health, spiritual health. But again, just to highlight how recent some of this research is, this was in 2017, the first ever randomized controlled trial to look at the impact of diet on mental health. And again, before this, it was sort of just assumed that that's kind of nonsense, that a diet was not going to affect mental health. It's all to do with serotonin and whatnot, and it's a genetic problem, and that's all there is to it. And that's just not turned out to be the case. There's now been 4 randomized controlled trials and a number of other randomized controlled trials that aren't specifically in depression that have looked at this. If you put people on a modified Mediterranean diet, which is an anti-inflammatory whole foods diet, 32% of those people with moderate to severe depression go into remission versus 8% in control. As I say, this has been repeated in adolescents now, it's been repeated in older adults and 2 in sort of midlife adults. And this larger meta-analysis was done with over 45,000 people in what we call non-clinical depression, so a slightly different definition, and showed similar results. It's stronger in women, the effect. And what's the mechanisms of this? I mean, it's not like this is just sort of touchy-feely stuff that, oh, people are eating better so they feel, a bit better in their head. No, these are having biological, cellular, and molecular impacts because we are we are giving the body what it needs to operate. And so if we give it better substances to operate, it will operate better. It will try and heal. I often use the analogy, if any, I'm sure you're all homeowners or home renters, but if you ever had to deal with weeds, weeds growing in the driveway or in the garden or whatever, it's like you can try and spray it, cut it, do whatever you want, but within 2 weeks, out of the cracks in that cement, another weed is growing. And he's like, I mean, you've just got to respect that level of perseverance. And this is what our own biology is like. If you give it the opportunity, it will try and grow. It will try and heal. So when we do that, we can look here, and I cut out some of the picture kind of with exercise to make a point that they each activate these similar pathways. The HPA axis function, which I talked about in men's testosterone as an example, but that also impacts every other thing that the pituitary interacts with, aka the adrenal glands, the ovaries, the testes, the thyroid, etc., etc. It promotes neurogenesis, which is brain-derived neurotrophic factor, as an example, which is very important for synaptic health. It reduces oxidative stress because you are giving yourself a lot of antioxidants, so the mitochondria can function far more efficiently. You can actually create more mitochondria so the mitochondrial density of cells increases substantially. Okay, more mitochondria, so they're working better, and there's loads more of them. Well, what does that mean? If a cell has more mitochondria, it has more energy. It can do its job better. And what is its job? Well, that depends on the cell. If you're a neuron, you're information processing. If you're a microglia, you're managing inflammation, neuroinflammation in the brain. If you're an immune tissue, you're doing your fighting or you're repairing. If you're a liver, you're metabolically processing energy. So you are giving the body the best chance it can. And gut microbiome is a huge, fascinating topic, but I'm not going to touch on it tonight. Kynurenine pathway, another very interesting topic. So there's many, many aspects here that we're helping. Again, not to make it sound like a panacea, but we have to get these foundationals right, and we will see a massive reduction in the need for the other approaches which we should save for when we do really need them. And within this, again, there's massive opportunity for good research here. At James Cook University, we're currently performing now the first randomized controlled trial in the world looking at ketogenic diet, whole food, plant dominant ketogenic diets in schizophrenia and bipolar for psychotic symptoms. And to me, to imagine that we could come up with a lifestyle approach for people to treat their psychosis, which is such a disabling, horrible illness, to reduce, therefore, their demand, not necessarily eliminate it, but reduce their demand for antipsychotics, which, yes, can be life-changing, but also have considerable side effects. It, to me, is a very exciting avenue to pursue because it also improves, weight and metabolic disease and a number of other things. And I think people deserve that option. Whether they take it or not is, at the end of the day, informed consent. But we have enough trials here we have enough research now to justify the first randomized control trial. The scientific process has been followed. We saw in animal models, which is this bottom right paper here, the impact of ketogenic therapy on the brain health, and I could talk about specific mechanisms. Then there were various cross-sectional studies and pilot trials done, each showing that you can see a considerable reduction in positive symptoms as well as negative symptoms. Positive symptoms meaning psychotic symptoms, delusions, hallucinations, thought disorder, and negative symptoms meaning depression, anxiety, and so on. So a very exciting avenue to me. If we look at movement, most of you will know that movement's very good for your mental health. The question is how good and what types. And again, there's nuance here, but we can make a general rule that any movement is better than no movement. We don't need to research this anymore. We've got over 1,000 trials now. 120,000 people have been studied to show that exercise is good for your brain. The Cohen's D, which is the effect size in these studies, or the standard mean deviation, the effect size, again, they're similar, but 0 means no difference between intervention and control. 0.2 means mild, 0.5 means moderate, and 0.8 means large effect size between control and intervention. This is the same for standard mean deviations, which is the SMD or HSG and so on. But what they saw was that exercise it gives us an effect size of about 0.43 on depression and anxiety. That is comparable, if not greater, than the effect size of antidepressants. Antidepressants effect size is on average minus 0.35. That's higher for severe mental illness, and that is when it is absolutely justified, and much, much lower in mild to moderate depression, which is why it's not recommended in the guidelines to be prescribing antidepressants for mild to moderate depression. So exercise has definitely got a place in there. What I'm further fascinated about, this is a study that was published last year. Again, this is where it gets exciting to me because of the nuance of this. How can we combine lifestyle interventions with pharmacotherapy? How can we combine lifestyle interventions with psychotherapy to get the most out of each intervention? There is a symbiosis that occurs here. So as an example, in this study, what they showed was that you can do your psychotherapy, that's good, mental health get better, that's good. But if you do your exercise after your psychotherapy, we can actually see brain changes. We can see the consolidation of the learning that occurred in that psychotherapy. We can see subsequent recall of fear extinction learning, aka the sort of process that happens when we go through, say, anxiety and exposure and response to that, and our anxiety gets less with time. This process is much more effective if people exercise after their session. And if you go for a walk after if you've ever done psychotherapy, which I have, you will often things will start making sense, right? Oh, I understand where that memory comes from and why I do this, and that's what this is related to, and I reflect on this, and here's some automatic thoughts I'm doing, and so on. So we can combine these things. Now I'm going to look at a few other brain aspects, so I'm sort of sitting in the mental health space or cognitive neurological health for a moment. This is a paper published again last year in the Journal of Alzheimer's Disease Reports. It's not the best paper because it's a very clinical, real world paper. And what I mean by that is it's not a highly funded randomized control trial. It's literally a bunch of neurologists just trying to do awesome, good care, and they're just collecting their data. And they've collected good data. So that's great. But it's not as high level as some others, but I think it deserves attention for a few reasons. The first is there was a decent cohort, 220 children and adults covering ADHD, traumatic brain injury, and cognitive impairment. It was lifestyle coaching, lifestyle medicine, and some neurofeedback twice a week for 12 weeks. So not an overly onerous program. This is elements of the program. So you can see very much lifestyle medicine oriented, Mediterranean diet, sleep, exercise, meditation, omega-3 fatty acids, brain training, which is cognitive training. And these are the mechanisms which we would expect to change: an improvement in synaptogenesis, aka rewiring, refiring of neurons; glymphatic function, which is the cleaning part of our brain, which largely switches on during the night, cleans a lot of the metabolites of the day, aka beta amyloid, which accumulates in dementia, for example; reduction cortisol, improved brain-derived neurotrophic factor, and so on and so forth. So yay. And what they saw, there's a few things I love about this. This is busy slide. So just maybe listen. But what they saw was that everything got better. So neurocognitive, verbal memory, complex attention, processing speed. And this is the percentage of patients who scored better at the post-program for compared to pre. About 60 to 80% of people got better across the board. The BAI and BDI is Beck's depression and anxiety indexes. The PERS 20 is the Pittsburgh sleep inventory. The ESS is the Ipsos sleepiness scale. So their sleep got better, their anxiety got better, their depression got better, their brain function got better across the board. And so I also love that they created their own little questionnaire and clinical tool here. And it's a very simple tool, but it's a very effective tool. You do things like this in your clinical space, will be amazed at what comes out of that assessment, about the opening up that happens with patients and the solutions that present themselves through that process. And I think it's very positive because we've got sort of concepts in medicine that say ADHD, well, it's Ritalin, right? Well, no, it's not just Ritalin. There is an enormous amount we can do to improve brain functioning and health, and I think it's dangerous to assume that every inattention is sort of a genetic disorder. And obviously ADHD is a real disorder, so I'm not denying that for a second. And as I say, we can identify the mechanisms here. We can and again, this is a busy slide, so I'm actually going to move on. But the point is that different parts of the brain, whether it's neurons, whether it's microglia, whether it's astrocytes, whether it's the lymphatic function of the brain, they all improve. The brain becomes less inflamed. Synapses, synaptic clefts increase with neurotransmitters. They function more effectively. There's less receptor resistance and changes. And then what do we see because of that? Mental health benefits, cognitive benefits. We see improvements in fatigue because the brain is one of the sources of sort of chronic fatigue. There are obviously many. Pain sensitivity and central sensitization improve, and so on, and resilience improves. Now to look at, Alzheimer's. This was published only a few months ago. Again, lifestyle medicine intervention, randomized controlled clinical trial. And this is, worth sort of breaking down a little bit. Oh, I realized I'm a little bit late on time, so hopefully you're enjoying the talk enough to continue listening. But this is 51 people with a mocker of 19. So everyone who knows sort of dementia screening tests, 30 is a normal score, and it's pretty easy to get a 30. It's a simple orientation, memory, and calculation questionnaire. If you're getting 19, there's pretty significant impairment somewhere in this cognitive function. It was a 20-week lifestyle medicine program with a bit of omega-3 probiotics and lion's mane mushroom thrown in, which is common, not perfect, but confounding, but also very real world. They used all the same tools that they would use in dementia trials, the AD assessment scale, the clinical global impression, et cetera, et cetera. They also then looked at a raft of biomarkers. And here you can see, and this is, keeping in mind, these are roughly 80-year-old people with established dementia. And you can see here that the various scores either improved or slowed down compared to control. If we look at the bottom here, you can see that in the control group, everyone got worse. They either got significantly worse, or they got a little bit worse, or they stayed much the same. But that shifted, the bell curve shifted with the intervention group. Some people got better. Many more people stayed the same, and only a few people got a little bit worse, but no one got significantly worse. So again, not a panacea. But what amazes to me is even at this stage, even when we think it's kind of too far gone, the brain is too damaged, it still is fighting. It still is holding on to that process that it still can have some degree of healing. If we look at the biomarkers that were collected, you can see here, insulin levels went down, cholesterol went down, inflammation went down, the telomeres got longer, even in this population. The plasma beta amyloid ratio improved. And what does that mean? It means that there was less amyloid burden in the brain, and it was being sucked out of the brain into the blood. So the body was actually removing amyloid when it was given the support to do so. And there was a big change in the microbiome. And all of this comes down to sort of personalized lifestyle medicine, because that's, to me, the future. I think that there is an enormous potential for the combination of artificial intelligence, research, clinical skill, and the art of medicine to combine to create personal lifestyle medicine. I am so excited about what could come of this. How can we respond? I mean, there are studies I haven't shown you tonight on rheumatoid arthritis, on various other conditions, that what can we do with autoimmune diseases and cancers and the various other sort of diseases when we actually personalize these things well and intensively? This study, which is a little old now, 2015, published at Tel Aviv in Israel, 800, just as an example of the importance of personalization, because I will sometimes hear about, same diet for everyone. It's just not the case. Yes, there are general principles that are true for everyone. I think that's a fair point. But this 800 people study, they gave them exactly the same meals. That's a lot of meals, right, over a long period of time. And they measured the various biometric outcomes. And they saw there was huge variability between people in their insulin levels, in their glucose levels, in the time until they got hungry again, and so on and so forth. And from there, they derived a, machine learning algorithm and so on and so forth. But that really is the future. So all of this adds up, right? All of this, it's effective. Not again, not a panacea, but it still can be very effective or mildly effective across many domains. It's biopsychosocially beneficial and culturally and spiritually beneficial. People want it. And I didn't actually put that slide in, so silly me, but there have been studies here showing that on average between 80 to 85% of people really, really want this as a part of their care. And there have been big studies, especially around diabetes, surveying people with diabetes, saying they are really frustrated that they're not being offered this care and they have to go to the internet because it's not being provided by the healthcare provider. That's the wrong way this should be going. We should be providing and filtering that to give them the best evidence-based holistic care. It's largely safe and we know the mechanism of action. This is a little note from one of my patients um, off medication, the various things that we did, and it was just a thank you card that they gave me, which is very sweet. And it helps us too. There's been studies here that practicing lifestyle, this is published last year as well, practicing lifestyle medicine reduces burnout rates and improves job satisfaction of people doing it. And that makes sense. So in the time that I don't have left, I'm going to talk a little bit about implementation. And because fundamentally we need to talk about how do we connect? How do we connect this amazing research into practice? And that's, the translational gap. And that's a big, important question. That's where I do a lot of my work. And because the reality is that, yes, we've got drugs and we've got surgery and they're awesome. We've got drill presses and they're a great tool. We need that tool, 2 thumbs up, but we also need other tools in the toolbox. Sometimes you don't need a drill press. Sometimes you need a hammer or a screwdriver, and this is that situation. So how do we implement this? So we sort of published this little infographic graphic a year ago. And to talk, just to help people conceptualize this, that yes, you've got your one-on-one care. You've got your care as a GP or nurse that you provide to a person one-on-one, and you can bring lifestyle medicine interventions at pretty much every condition, every level, every stage, essentially. You can significantly enhance your skills with health coaching, behavior change, utilizing other aspects. So that's one element. But if we zoom out, we think about, okay, but what about the model of care? How are we using our team? And this is a big question, lots to say. How are we using our nurses and our GPs and our receptionists? How are we using the physical built environment? Are we optimizing that to the best of its ability? Are we using nudging and behavioral insights to support behavior change? How are we connecting with other services? How are we connecting with our community? An example of this I could give is one thing we've done in our clinic. I've now done this in a few clinics as a consultant, is we will do a map of assets within the community, legal services, accommodation supports, domestic violence supports, men's groups, women's groups, free gym classes, free things, whatever. There's a surprising amount of stuff in the community that is unknown to us. We map that, and then we provide a social assessment, and then we map it accordingly to what exists in the community. So whilst people are sitting in the waiting room, they're being assessed for their social needs and they're being provided solutions to their social needs before they've even seen the doctor, because the model of care is facilitating lifestyle and social care. We again publish this, what's called the reverse Swiss cheese model. And again, it's a conceptual thing to kind of make it, it's a humbling point to make the point that no single intervention is perfect. Every single intervention is imperfect. It has holes in it for whatever reason. People won't stick to the diet or, whatever. But the point is that we build in layers into a person's life and into the way we deliver care. So it's not all relying on a GP or a nurse just to do everything, that we are all working together. We're bringing in peer support. We did one of the first, I think the first peer support trial in primary care. We just got an MRF grant for it. Well, we finished that, sorry, a grant for it. There are many ways that you can build this into primary care. Accepting that none of them are perfect, but the more layers you have in, the more likely you are to intercept and support that person. When I'm teaching, I often try and get people to think systematically about their model of care and where you can implement and evaluate it. Now, the evaluation is key. It's, again, something we haven't done traditionally well. Health assessments, GP care plans. I mean, none of that is quantifiable particularly. And so we have no idea if things are improving or worsening over time outside just sort of anecdote. If we can, there is so much opportunity to evaluate what we're doing so that we know that it's actually doing what we intend it to do. But we have to learn a little bit about models of care and implementation science to do that. And that's training that most people don't get who are clinicians, and it's a gap. but it's a gap we try and satisfy within this postgraduate degree. So if we think systematically, what is the patient journey? From the moment they thought of you to the time they called the reception to when they booked in, they're sitting in the waiting room, when they're in with you after the appointment, who's following up, who's supporting behavior change? Are there high yield points? I mentioned antenatal care and I mentioned preoperative care. There are various other opportunities. Can we be proactive? Can we develop events or online modules? Why is it that a person comes in with diabetes and all I have is sometimes this single pager to give them? Why don't I have an online module telling people everything they need to know about diabetes and how to reverse it? Why is that not standardized? It should be standardized. And of course, that's got to be, we've got to use it all. As an example, this is a study published in the Netherlands, and it's been sort of repeated, so to speak, in New Zealand. The man in the right here is Dr. Glenn Davies, a GP in New Zealand. And it's a reverse type 2 diabetes program, and they had groups, they had practical events like cooking classes, and social media like a closed Facebook group. And what they saw is 50% of people reduced their medication after 6 months. 50% of people reduced their medication after 6 months. And there's no medical intervention here. This is a lifestyle social intervention. I'm not going to talk about shared medical appointments, simply to say that there is a large body of research to say, instead of seeing 8 people with diabetes and giving them 10 minutes of your time each throughout the day, why don't we get those 8 people together or 10 people together and see them all at once? We can say they can get more time with us. They can get an hour and a half with us. So that's a win. They still get their needs met. There's a lot of peer-to-peer interaction, which is really, as I say, the magic source that sort of happens with here. And there's multiple studies showing it's more effective than one-on-one care and more cost-effective. And we're now doing, and this is an old study now, but there are much more recent ones, but changing that model to what are called medical yarn-ups or shared medical appointments in Aboriginal people. And it's much more congruent with traditional concepts around health, aka the healing circle for some Aboriginal people. And we see very high levels of satisfaction for this type of care. If you've worked in Aboriginal healthcare, you know some of the challenges can be adherence and those sorts of things. But if we actually change the way we deliver care, we see adherence increase. And so it's not a problem per se with people. It may be a problem with the way that we're delivering this. We're expecting everyone to match this one-to-one style healthcare. But let's just think broadly about how we can do this a bit differently and again address those lifestyle social determinants. Here's another wonderful example led by Professor Darren Morton at Avondale, where he developed a lifestyle medicine and positive psychology online module program. And they've done randomized control trials here showing that this program reduces depression and anxiety, but beautifully also increases vitality and well-being. So the positive aspects we're starting to measure as well, not just the reduction of negative, but the growth of positive. The beauty of this program is its intelligent placement. This is currently being sort of rolled and funded in various PHNs now as a waitlist program. So when people are waiting those 6-8 weeks for their psychology, for their mental health care plan or Head to Health or the Medicare mental health centers, these are the sorts of programs we can get people doing to get the ball rolling nice and early, that's guided, that has workbooks and quizzes and group support and forums. So we can actually start engaging people rather than just waiting and doing nothing or doing little. Another example in, say, the mental health space would be when people are in acute distress. Again, it's not just all about chronic disease. This is just a snapshot of a document that I give out to my patients. When and I'd love to tell the wider story here, but when I was working in the public health unit and we were implementing lifestyle medicine programs there, studies as well as our internal data showed that when people present with acute psychological distress, about 75 to 80% of the time, they are given sedatives in response, benzodiazepines or antipsychotics, or both. 2 milligrams of lorazepam and 10 milligrams of olanzapine, the 2 and 10 combo. And no other intervention is offered. We did a small internal trial, and this generated some of the worksheets that I've done. But if when people attend to us and we ask them to rate their distress out of 10, 8 to 10 is severe, 5 to 7 is moderate, and so on, and we give them a matched, co-designed, co-created management plan for that's lifestyle social orientated, then we actually found that 80% of people preferred to do this and stuck to this non-drug interventions rather than go to medication. So that's great. We've seen less medication dependence. But what that really means is we've improved empowerment. We have helped people understand that distress is temporary, that there are things we can do to soothe and improve our own resilience. And if you need medication, you should have medication. You should not be denied the care you deserve. But we can avoid that and, avoid the potential side effects, addiction, and withdrawal that comes from those things. And social needs, I've touched on this briefly in the sense of giving you some examples, but there are various models of care in New Zealand and UK. We're, fingers crossed, going to find out about some big funding we might receive in Australia on this point very soon. But when we look at developing models that involve the community, we see significant reduction in demand on GPs. And so this type of model, called Altogether Better, is where they put an expression of interest out to the community to say, do you want to volunteer your time to the community and run something? Cooking class, Tai Chi classes, carer support, help in a flu clinic, make cups of tea in the waiting room, whatever it is. It's filtered, obviously. You don't just get anyone coming in, you get your select volunteers. They've now done this in over about 400 practices in UK. 25,000 volunteers have been enrolled. Hundreds of different types of classes have been set up. And they've seen not just people being happy with this care and the staff being happy with this care, and the primary care being celebrated as the champion of local health change, but they've seen reduction in emergency visits. This is all studied and published. They've seen a roughly 30% reduction in the demand on GPs because the psychosocial needs are being met. Now, some GPs may be intimidated by that because they say, well, I get paid for what I see. But if you're like most GPs at the moment, where you've got a 4, 6, 8 week waiting list, I'm very happy to have 30% less patients. That's a good thing. Leave the complex chronic medicine to me as a GP. If the community can help with the psychosocial elements, that's good because that's what's missing. Yeah. So that's pretty much it, right? And am I a little over? I'm a little over, only 5 minutes, not too bad. But I highlight this again, just this slide to make the point is that the potential, we are really only at the infancy of this field. Some of these studies are impressive, but we are actually really at the infancy of this field. If in the last 5 years, we've seen a number of good quality publications in good quality journals come out. But that's only in the past 5 years. We have so much more to do. We have so many more diseases to study. We have so much more to do on the personalized lifestyle medicine aspect, on the intensive lifestyle medicine aspect, and on the implementation. AKA, how do we do this in primary care? How do we do this in hospitals? How do we do interdisciplinary care? It's a lovely word, multidisciplinary care. It's a beautiful word, but how do you actually do it in the community? So these are the questions that we are seeking answers to. If you're interested in lifestyle medicine more broadly, please do join the Australian Society of Lifestyle Medicine. It's about supporting, growing this movement. The Australian Society of Lifestyle Medicine is a lovely organization. You'll find your tribe if you're interested in this, so please do consider. As I said, I'm not quite sure where we're up to, but 30, 40 maybe different societies and colleges around the world in lifestyle medicine. The American College is the biggest. I think they've now got about 20,000 members. And the British Society is another very large body. So there's some really impressive work being done around the world here, and it's just growing. Harvard, University of Edinburgh, Imperial College London, these all now have lifestyle medicine programs, either postgraduate or undergraduate. If you are interested in doing a quick 3-week micro certificate and getting your last CPD hours needed if you're a GP for the year, we created this course, JCU and Deakin, to talk about lifestyle medicine and implementing it in implementing it in mental health care services. And we have case studies from psychiatrists, GPs, exercise physiologists, nurses, dietitians, all in how they brought it into different settings to implement it. What were the core constructs? What were the lessons learned? Health coaching, behavior change, medication optimization, disseminating it, evaluating it. It's like a intensive introduction to doing this. And now, if you're interested in studying with our team, there's obviously myself as the lead of these courses, but we have dietitians, health coaches, we have many other GPs, psychiatrists, neuroscientists, public health physicians, exercise physiologists, all have reviewed and contributed to this wonderful course. If you have questions, please contact me, sam.manger@jc.edu. These postgraduate degrees are available for every health professional. And if you're not a health professional, you can still write to me and I can consider your application, but it's dependent. They are online, so it's flexible. I review all recognition of prior learning. So if you have a fellowship in general practice, if you have a master's in something, if you have some research experience, I'm more than happy to review and reduce the elective burden for you, reduce the time and the length. For example, I think for those who fellowed in GP, I think about a third of the masters can be accounted. There's Commonwealth supported places. As I say, we cover a wide array of clinical and research and implementation science. And if you finish your master's, you will also can be awarded your fellowship in lifestyle medicine with the Australian Society of Lifestyle Medicine. We have pathways for becoming an accredited health coach with the Health Coach Australia New Zealand Association. We have PhD pathways. We have graduate certificate research pathways as well, which is included within the master's. And we have cross-institutional pathways. So if you want to do your electives in medical nutritional therapy, culinary nutrition, health coaching, and various other things, I have created pathways for you to do that. My fundamental goal with this training is to be valuable to your career. It's not about ticking boxes. It's about being valuable. So I meet with every master's and graduate diploma student once every 6 months. I help talk about where you want to go with your career. I'll help network you with people. I'll help shape your research so that you can get the absolute most out of this. It's a very personal course. I know every student pretty much because, like I said, it matters to me that we make this change in healthcare and that you're supported to do so. So that's about it. I'm just going to stop sharing. Oh, no, sorry, there's a survey. So if hopefully you enjoyed my talk tonight, there is a survey. I'm going to leave that up for a little bit whilst I just answer some questions. All right, so thank you, everyone. Let me just look at the Q&A here. Okay, so Biz, Mickey, if you're confused about the handbook, that's fine. You could probably just email me that one. There are 5 or 6 core subjects: Introduction to Lifestyle Medicine, Health Coaching, Behaviour Change, Models of Care and Implementation Science, Research Methodologies, Advanced Clinical Lifestyle Medicine or Lifestyle Medicine Prescription, and then your sort of master project. So that's the cause. And then there is a list of internal electives that you can choose from: public health, business, health professional education, Aboriginal Torres Strait Islander health, or there are the cross-institutional ones that I mentioned: nutritional, medical nutrition therapy, culinary nutrition, and so on. So hopefully that answers your question, but feel free to send that feedback to JCU if you think the website's a bit confusing. That's outside my control, but I respect what you're saying. Is it only weight loss that reverses insulin resistance? No, it's not. So if you look at it, what does exercise do? So let's say you stay exactly the same weight, but you start exercising. What do? Well, if you exercise after you eat, you are going to be using those calories. You are forcing your body to become more insulin sensitive. And actually, diabetes, the diagnosis of diabetes is typically preceded by about 5, 10, 15 years of worsening insulin resistance. Often it starts peripherally in the musculature and obviously progresses to the liver and so on. There are many ways you can reduce or improve insulin sensitivity, physical activity being one. There was a meta-analysis done, I think, last year as well, where they looked at mind-body intervention, so meditation, and it showed that on average, meditation reduced HbA1c by about 1%. Why is that? Because you have less cortisol in your system, and therefore you have, cortisol increases blood sugars and stimulates insulin resistance. So again, this is a holistic approach. Weight loss for sure can do it because weight is inflammatory, because unhealthy foods are inflammatory, and a raft of other sort of reasons which we go into detail. So weight loss, bariatric surgery, for sure can treat reverse diabetes, but you can do it in other ways as well. Can you provide, anonymous, can you provide tangible advice we should give to our patients ourselves? What kind of hopefully you've been listening to this talk, and there's plenty of tangible advice within that. Everyone has their different style. So there's a great line from Bruce Lee, which is, "I do not fear your 10,000 kicks. I fear the one kick you practice 10,000 times." And the point of that is, where are your strong suits? So I have always loved educating. I've always, even when I was a med student and I was an intern, I was still educating the people. When I was an intern, I was educating med students. When I was a resident, I was educating interns. When I was a GP, I was educating registrars and so on. So I've always loved being part of that process. So naturally, therefore, my clinical style is going to be a little bit more educational. I like bringing up these things with patients, and they love hearing it as a general rule. So I do start with that, but then I build on health coaching, goal setting, motivational things, values, and so on and so forth. So that's an art and a science. I'm sorry I can't give you a super quick answer, but what I'm saying is practice one thing, do it well, and then you will find benefits. So just start, for example, assessing lifestyle determinants. Assess diet, movement, physical activity, sorry, diet, physical activity, sleep, social connection. That's a big one. If you ask people how socially connected they feel, are they lonely in their life, you are likely going to open up a can of worms, and you are going to come, and they're going to come up with the answers themselves. So starting with assessment may be actually my tip to you. How does screen time affect attention and health? What are actual guidelines to aim to adhere? Well, because screens are kind of new, inverted commas, in our society, we don't actually have a real good guideline. The physical activity guidelines is where the screen advice is at the moment, because it's correlated with sedentary behavior. And it says, kids under 2 should not have screens 1 hour between 2 and 5, and so on and so forth. The first, but this is not a well-researched area, which is surprising given this technology has been around for 15, 20 years. The first ever meta-analysis to look at the impact of screen use on mental health was only published in 2022 or 1, I think. And amazing, that it took 14 years to do our first meta-analysis on the impact of screens in our population. And what it showed that is it, on average, trends with poor mental health. But if you look at sub-analysis on problematic social media use, and that's defined as people checking first thing in the morning, people checking when they're on the toilet, people having an urge to check, checking when they shouldn't be checking, aka when they should be working, which I think, if we're honest, that's most of us. Then it does correlate pretty clearly with depression and worsening mental health, and that is concerning to me. Long-term outcome of dietary intervention. Yeah, so that's an interesting one. There's actually been, so this is a long-term outcome of dietary interventions. Yes, adherence for weight loss is a problem, but partly that's because we're focusing on the weight rather than the metabolic benefits and the sugar benefits and so on, and the mental health benefits. And a lot of research now, when we're looking at lifestyle, is saying don't talk about weight. Just don't look at that number. Measure well-being, measure mental health, measure sugars, measure inflammation, measure cognitive impacts. That's what really drives people. We all know, as I said right at the beginning of this talk, long-term things are not something that most humans are driven by. We are driven by our experience, and we are driven by our short-term rewards. And so we need to adjust that. The weight loss thing is a really, really big question. It's not quite true that 95% of people fail at 5 years. The look ahead trial and a number of other trials show that it's higher than that, but not a lot higher. And that's with the sort of older style way of doing it. And yeah, there's studies on, say, various diabetes specific processes. Studies now ongoing about 5 or 7 years, and they're seeing good rates. But again, I'll be super clear here. I'm not saying it's 100%, absolutely not. I would say that long-term adherence fluctuates significantly and depends on the condition and depends on how bad they get when they stop doing it, aka when they stop exercising, their mental health gets a lot worse. There's often an incentive to start exercising again. Tamara, is the course all online? Yes, it is all online. There's one exception to that, which is the elective in culinary nutrition. That is a blended online and in person. There is a challenge motivation patients that all respond to educational evidence-based strategies. Yeah, that's true. That's absolutely true. The first thing I sort of teach about health coaching is to just accept the reality of human nature and don't burn out just because people don't change when we say they should change. Humans are humans. Some people, but what I will say is that also don't assume that no one will change. I mean, maybe you've been burnt by patients who didn't change. Maybe your consultants, when you were training as a med student or whatever, told you because they were jaded and over it that patients never change. Just give them meds. I'm sorry to say, but that is a strong attitude in medicine. It's somewhat inbred in the training to somewhat that don't, patients don't change, don't bother trying. When they actually do reviews of models of care here, and they look at the barriers to this, aka implementing these lifestyle social determinants, one of the main barriers is sadly staff attitude and culture. It is this stigma we have that humans are, not going to change. So the first thing I'd say is I'm going to really challenge that attitude. My experience is, I mean, I see a lot of second opinions now. A huge number of patients who are not getting this type of care from their usual care team, and they're coming to see me just for that. That's not how this should be. Most of us should be providing this kind of care, and it should be part of the service. And when it's automated and it doesn't rely on us to be perfect in our consults, then that's a much better way to go about it. Now, I've often said over the years that it's kind of rules of three in my experience. And what I mean by that is when I bring up lifestyle medicine interventions and approaches, I find that roughly 1/3 of people are pretty keen to engage right then and there. 1/3 of people are like, yeah, they're kind of warm to it, but they want to sit with it for a bit. Often they'll sit with it for 3, 4, 5 months. They'll come back and see me and they'll either say, yeah, I actually started that, or I'm now keen. And 1/3 of people just, they're not interested. you know and so I'm not going to stress myself, quite frankly. I'm going to offer them the care. They make informed consent, they decline. I might put in a few follow-ups just to make sure, but I'm not going to burn myself out over it. And that some people just need a lot more time, but I see no risk in throwing out those seeds. You don't know which ones are going to germinate into plants, and you don't know which ones are not. But I would say that it's worth throwing them out with every person. But you're right, it is challenging. But again, in the way that we're doing medicine now, we're assuming that a GP can do all of their stuff, which is already a lot, and then add on and become an amazing health coach and behavior change scientist with basically no training, and by themselves, because the nurses aren't, the team isn't going to be part of it because they haven't had the training either. We just say, go do a better exercise. I'll see you in 6 months. That's not going to work. People need much better support. They need much better information. They need much better understanding of what's going on and how it's relevant to them. And you mentioned education, and that's the difference between education, aka you have diabetes, you need to eat better, and therapeutic education, which is a real term. And they've done a lot of studies on this in chronic pain. And when people really understand what's going on and how it's relevant to them and how what they're doing in their lifestyle is actually contributing to that, you see a much bigger shift in adherence and change. And that's why I say I'm an advocate of education, because I use it as therapeutic education. So there's a lot within that, but I guess to come down to a few strategies, I suppose therapeutic education around, as I said to the other person, pick 1 or 2 techniques, assessment and opening up the question, and that's all you do. You'll be surprised at what comes out. And consider your team. The RACGP have created an app called Healthy Habits, where you can log people and set goals and send one-way messages and support them in that way. But there are lots of ways to do it. Peter, I've heard that continuous glucose monitors can be insightful for some people. Is there any such thing as continuous cortisol monitor? Yeah, I mean, CGMs, continuous glucose monitors, can be really useful for some people. If they've got diabetes, they can see very clearly what is spiking their sugars. And that is what I mean by that's a digital form of feedback, biofeedback, or therapeutic education. The number of people I've set up CGMs for, and they come in and they say, whoa, I had no idea. I had no idea these foods were doing this, right? I just watching it, bing, it goes up. Well, I just cut that out. Easy, done, right? And so for people who don't have diabetes, it's a bit more controversial. And I would love to see, I'm not aware of any continuous cortisol monitors. Over the years, various tech groups have released like sort of bedside CRP markers or inflammatory markers or interleukin markers. I'm not aware of any cortisol ones. I think that would be it's sort of the holy grail to find those sorts of biofeedback tools that will improve not just understanding but also adherence. We're seeing this a little bit with sleep trackers and heart rate variability monitors. They're a certain type of personality that really like those, and that's fine. Whatever helps people change helps people change. But I think again, lots of future opportunity, and the medical tech world is spending a lot of money on this, because likewise they're looking for ways that you can track these things to give people real-time feedback to improve that adherence. And I suppose the other thing around motivation is that you may have, this is anecdote now, I don't know a study, so I'm just disclaiming this is not evidence-based per se, but more people, especially since COVID, more people are interested in what they can do to improve their health than I've ever seen before. Of all ranges, of all backgrounds. Now, of course, that's not everyone, but there is a reason that everyone is going to the internet to do this. There's a reason that everyone's reading these things on Facebook. There's a reason that this big supplement industry is making billions and billions and billions of dollars, and pharmacies are stacking supplements, is because people are trying to sort this stuff out. There is motivation there. Maybe it's not motivation to change their diet, but maybe it is motivation to exercise. Maybe it's not motivation to exercise, but it is motivation to connect with their best friend again, which is social connection. So we have to be very conscious, meta-conscious of our own agenda, thinking, no, you have to change diet. That may not be the path to change for that person. I can give many examples where the path to change was a keystone experience, a connection with an old mate, a bit of information at the right time, or a bit of wisdom at the right time, maybe a physical experience. I will actually do breath work with my patients in the consult. And just 1 or 2 minutes, and having that experience about how their psychological stress went down 30–40% just in 2–3 minutes is a profound experience for some people that goes, okay, well, I've had the experience. I know what I'm aiming for now. I want to change. So anyway, I'm going off. I'm tangenting now. I've had a long day in my clinic, so apologies, but hopefully that answers your question. All right, so I think we're done, and thank you so much, everyone. I hope you enjoyed it. I hope you found that valuable. I hope it was seen in the context of everything I'm saying with respect and love for our profession and the great work that we're all doing, and really just with the intent to help us all, as I say, kind of help evolve. The reality is, when in the 1930s and 40s and 50s, when the major cause of disease and death was acute problems, trauma, infections, complications of childbirth, these were the things that were killing people. So what did the medical system do? It responded. We came up with antibiotics, intensive care, better childbirth processes. We researched vaccinations and so on, and public health and sanitation. And now we have much less of a problem in those. It's not a zero problem for sure, but it's less of a problem. The burden now, though, has changed. And therefore, my opinion, respectfully, is that we need to change. And I'm not saying that's easy either, but the more people that we bring together, I think the much greater chance we've got of achieving that. All right. Well, thank you very much. I can't see anyone or hear anyone, so hopefully there are still people here. Thank you very much, and I wish you the best.